We need to shift the thinking to not how is this going to replace me, but how does this augment the system and give me new roles? I go back to our good friend Amandeep and her conference, Creative Careers in Medicine. Some of these careers in medicine are going to be very different to what we thought we trained for when we went through med school. We need to work out how we're going to do that.
Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. This is our Hot Topic show and I'm your host, Louise Schaefer.
And I'm your other host, George Margellis.
George, you're all dressed up today. You're wearing a collared shirt. What's going on? You got a job interview or something?
No, nothing's quite so exciting. No, we just went out for lunch with my wife, so
nice.
She made me wear a shirt. I couldn't go out in my tracksuit.
Oh, good. What have you been up to, George?
Well, look, it's been a pretty hectic couple of weeks since last we spoke. I don't know if you saw it, but Four Corners had a expose on the aged care assessment tool. They call it an algorithm, but when you look at it, it's not really an algorithm. It's just a bunch of forms put together.
Yeah, it's like a decision tree, isn't it?
Yeah, exactly. So it's interesting because some people are trying to point the finger at us saying it's AI. I'm going, no, this is so far from AI. This is literally a decision tree.
Wouldn't it be nice if that was the problem in aged care?
Yeah.
That, like, we've got so much technology, it's gone rogue.
Yeah, we have so much data, we're using it effectively. No. Look, again, I remember a couple of years ago when they started the discussions, it was a matter of how do we determine what people's needs are? And it's not an easy thing to do. There's two challenges here. One, people are very complex as they get older. And two, old people don't like to say they're old. So they keep on telling you, I'm fine, darling. I'm fine. I can't walk, I can't eat, I can't drink, but I'm fine.
Yep.
So that's been keeping me busy. What about you, Louise? What have you been up to?
I'm not sure. I can't believe 2 weeks has gone by, George, but no, I've been busy doing stuff. Haven't travelled for a week now. So, Qantas will be calling any day wondering if I'm all right. But I did travel on the weekend, but I didn't use a plane. I went to Horsham, which is where my sister lives, a small country town, actually quite a large country town in rural Victoria. My nephew was in school play.
Oh, excellent.
And yeah, it was really fun. I couldn't believe the quality of the production. My nephew did very well, but it was in an actual proper theatre, and the stage direction, the costumes, the lighting, the backdrops, it was all professional quality. A far cry from the paper mache type costumes that we would have had when I was young.
Absolutely. I've been to a couple of my nieces and nephews' kids' plays, and yeah, they're a whole new level, aren't they? I mean, back in my day, we're basically still reading the script as you walked onto stage and pretending to know what we're doing. So good luck to it. I mean, maybe Australian drama has taken off. Maybe we'll soon have our own Academy Awards.
We do. We have the Logies, don't we?
We do.
No one really pays attention to those. Yeah. And then last week, I spent a couple of days with RACGP. So I've mentioned before on the pod, Greg Moran and I have facilitated a couple of the hackathons for RACGP in the last couple of years, and they're fabulous, obviously tech and patient and clinician-led. But this time, I worked with RACGP on something they called an engage-a-thon. So it worked like a hackathon in terms of small teams working to solve a problem. But they actually got staff who don't usually work together, and they worked on what should be the values of the organisation and workshopped it hackathon style over 2 days. I was so impressed, one, with the idea to do that and engage the staff that way. It was very impressive. So hats off to RACGP CEO Georgina for that. It was just incredible. But also what the teams came up with and how they worked and the pitches they gave at the end. It was very impressive. And I had a great 2 days, so much energy and enthusiasm in the room.
That's good to hear. I mean, look, the RACGP have definitely progressed in leaps and bounds. Michael Wright, their current president's done a great job, and he's been very visible. We've seen him at a lot of digital health events, really talking the talk and walking the walk. And I know they've just had their elections.
That's right. Congratulations to Dr. Ramya Raymond, who, was voted in by her peers and is now going to be the new president of the RACGP. So I think, George, we'll have to see if we can get Michael and or Ramya on the pod. We discuss topics pretty much every week that are so relevant to GPs. Today is no different. So it'd be great to get their perspective.
Absolutely. And I think one of our stories today highlights that, how important primary care is in delivering high quality care.
Absolutely, yes. Well, our first hot topic, George, I'm sure the RACGP would have a lot to say about it. Well, to say that our first story today is causing a stir would be somewhat of an understatement. A new JAMA perspective piece has come out which makes the argument that autonomous AI Not doctors, not clinicians plus AI, but actually autonomous AI will soon deliver the best medical care. The authors are bioethicist Ezekiel Emanuel, researcher Abe Baker-Butler, Curate's Health CEO Neil Koshler, and billionaire tech investor Vinod Koshler, someone who I actually met many years ago at Stanford University. And he was saying way back then, 10 odd years ago, that doctors would be replaced by machines. Now, they are saying in this article that AI will do better than doctors across 5 core cognitive tasks: gathering patient information, diagnosis, choosing tests, recommending treatment, and managing chronic disease. But their most controversial argument, as if the rest of that wasn't controversial enough, is that once AI becomes better than humans at a task, putting a doctor back into the loop may actually make its performance worse, because clinicians sometimes reject correct AI recommendations, and we've discussed that before on the pod. They can introduce their own errors or fail to use the information effectively. Now, their argument runs directly against the official position of pretty much every clinical professional body on the planet, or anyone who knows anything about clinical governance, who insist AI should stay in a supportive role. And it also directly contradicts physician and author Robert Wachter, who argues in his new book that AI-aided doctors will remain the gold standard, why AI-only care becomes medicine's sort of economy class. Now, George, personally, I continue to find these arguments exasperating, but the editors of JAMA decided to publish it, so I think we need to talk about it. What are your thoughts?
Well, like you, I've had the pleasure of meeting Vinod Koshler as well at Stanford at an event that I attended there. This was 10 years ago. He published a white paper promoting what he called back then Dr. Algorithm. Back then, he made the quote that 80% of what doctors do will be replaced by this Dr. Algorithm. Now, to his defense, he didn't say 80% of doctors will be replaced by it. He said 80% of what they do. And, he got a lot of flack at the time. The medical community's immune system kicked in and we all attacked him viciously to sort of say he had no idea what he was talking about and what does an IT tech guru know. And of course, he made a lot of money selling Sun computers. That doesn't give him the right to talk about medicine. But the interesting statement he made at the time, which again riled quite a few people up, but when you think about it, does give us an interesting perspective. He said that the practice of medicine would be replaced by the science of medicine. Now, as doctors, we all tend to think of ourselves as very scientific, but as he highlighted in that paper and has come to pass over the last few years, we do things in a certain way, not because of the science, but because of the socio-technical perspective of it and realistically what the reimbursement model does. So, it's a murky world, and he was controversial back then. He stifled a lot of interest and excitement in the sector, and we all came about saying no, no, no. And Neil Koshler, who's the CEO of Curate, is actually his son. Comes in handy when your father's worth about $13 billion when you start going into the startup world. It's always a handy thing to have. But the big surprise was Ezekiel Emanuel. Now, Ezekiel Emanuel is pretty much medical royalty. The Emanuel family are very well known. His brother was Obama's chief of staff. He was Obama's special advisor. He was on President Biden's COVID committee. He's a really well-known oncologist, bioethicist, and public health professional. And he's written quite a few books, and he's talked about how healthcare in the United States needs to be transformed. But he's not normally the sort of person who comes out with controversial statements like get rid of doctors and replace them with AI. So I think that combination is quite interesting. The fact that it's published in JAMA is even more interesting because if you saw this in The Atlantic or The New Yorker or The Economist, you'd say, okay, this is a opinion piece and designed to strike some discussion. But when you publish it in the home journal of the American doctors and say, hey guys, you're out of a job, that's really quite a thing. So needless to say, it's caused a furor. There's been lots of discussion. My LinkedIn feed has filled up. There's actually a Reddit feed talking about it. But once we get past that initial shock horror, someone saying in a medical journal that doctors don't need to exist, if you look at the paper, it's actually pretty well written. They've done their homework. They've actually brought in reasonable references. They haven't just used their commercial entity as an example. And they've noted the pros and the cons. They've noted that the reality is there are some flaws. At the moment, they're very much based on text-based medical examination. There's that brittleness between the LLMs and the consumer in that getting information from the consumer into the LLM still remains a bit of a challenge, and they haven't quite worked that out properly. But when it works well. But it has also generated discussion with the affected sector going, maybe there's more to it than just some controversy. It definitely provides food for thought. Some people are throwing it under the bus because the people who wrote it are tech entrepreneurs, but that in itself is not a reason to not accept its credibility.
Yeah, I agree. I think it's very well written. I wasn't expecting it to be, only because I saw the headlines as well. Oh, Koshlers once again are saying doctors are going to be out of job. And I'm like, oh, good grief, what have they done now? Anyway, but then when I read to the original source, I was like, oh, actually, they make a really cogent argument, I think, because, of course, they're not talking about actually replacement. It's certain skills. And I think, George, we've discussed before that the idea of de-skilling as being a genuine risk in medicine. And as a sector, we can't afford to be dismissive of these arguments because we really need to work out what's the combination of AI, clinicians and workflow that produces the best outcome for each clinical task, and when, if ever, autonomous care would be appropriate or not. And we certainly don't want to, throw away the idea of clinicians being de-skilled as it won't happen, or, we don't need to worry about it. Because if you look at the aviation industry, thank God for someone who flies on planes all the time, but thank God aviation has heaps of automation. But they responded to that automation with training, simulation, requirements to maintain that manual competence so that when the machines fail, the planes don't fail. We can't ignore these things. And it's happening just so fast. That's the thing that concerns me. Medicine's usually just so slow to react to these things. And I don't think we can afford to be slow.
Look, if this paper triggers us to have that discussion, then I think it's done a great job. Like you said, the way we practice medicine has to change. I mean, the reality is we don't have the ability to scale out this human workforce that we have. And whilst in countries like Australia and urban parts of America, we have access to services, there's the whole continents that have less doctors than I have in my local suburbs. So these are the sort of challenges we need to think about. There's a whole bunch of things we need to think about. Liability is brought up as an issue, but the reality is liability relates very much to the medico-legal aspect of it. And if we demonstrate that this is as good, if not better than the human element, then we really should be looking at the liability laws in a different perspective. Liability is not there just to punish bad doctors. It's also to make sure that systems are safe, and governance becomes a huge part of that. We've seen Health Direct here in Australia already starting to use some of these AI-based approaches for triaging. So let's work out what part of the medical journey is supplemented by AI and what part needs humans. Does it need doctors? That's another question we need to ask. We keep on saying we still need a human in the loop. Does that human need to be a doctor? Does that human need to be a governance expert? Does that human need to be an empathy expert?
Yep.
We really need to start thinking about what the models of care look like. One thing I did think about, because next couple of weeks, we've got the Creative Careers in Medicine conference. This may well be an opportunity for doctors to have to start to think about being more creative with their careers, because AI is going to take up a huge chunk of it. The thing that we define ourselves as, our diagnostic skills, our understanding of treatment guidelines, a lot of that stuff is now going to be engaged by an AI system. And as some of this evidence suggests, it does it as well, if not better. So maybe we need to rethink about the way we're delivering healthcare. Who do we need to train? What do we need to train them in? How do we pay for it? Next big question, of course. How do we pay for it? Yeah. And the reality is, if AI drops the price of the cost of our basic care, that frees up resources for things like rare diseases. We saw some amazing work published this week in Australia around mRNA vaccines for cancer. I mean, we can now start focusing in on those sort of things because we can use the technology to manage the bulk of chronic disease. Chronic disease management, they highlight as something which can be better managed remotely. And to be honest, it probably can, because it's a really tedious human experience to be on someone's back 24/7 telling them, don't eat that, do this exercise, whatever. But if the technology can automate that process and make it routine, and we heard about these personal assistants that prompt people to manage their wellness better than what they are currently doing, that frees up our resources for other things we can do.
Yeah, absolutely. Look, we will put a link to it in the show notes, and I encourage everybody to read through that JAMA article rather than just the headlines that talk about AI replacing doctors. It is worthwhile reading, and agree with you completely, George. We really need to not just rethink how we practice medicine and what we value, but how we can actually make those decisions in a timely fashion. And also, it's going to need to evolve. It's not like we've practiced medicine the same way for 100 years. And until there's a new diagnostic test or, we're going to keep practicing, as Eric Topol says, eminence-based medicine rather than evidence-based medicine. We just don't have time to mess around or just think, okay, we've made a decision today and today's decision is going to be the exact same in 12 months' time or 24 months' time. Like, we're going to have to work out ways of reevaluating how we care for people and what we pay for. We've got to invent new ways of doing that are timely and agile.
And what this article didn't even dive into at all, of course, is looking at the role of AI in consumers' own healthcare.
Oh, yes.
So we've had plenty of discussions about it. So it really is an interesting time for us all in healthcare.
Yeah, that's right. George, we're going to stick with AI for our next story. Now, this is something that was covered pretty widely in Australia, but I wanted to include it because I don't think many of our international audiences would know about it. We've gone from our first story, billionaires arguing that AI should replace doctors, at least part of what doctors do, into this story, which is grounded in a very real, very human story about what happens when AI gets it wrong. Now, a woman called Rebecca Green went to see a urologist, and like most of us now, she was asked if she'd consent to the appointment being transcribed by an AI scribe. She said, yep, didn't even think about it. Now, weeks later, after kidney stone surgery, she read her own post-operative letter and found that the AI had fabricated something that was just not true at all. It said that she had been microdosing psychedelic mushrooms and that this could explain prior bleeding around her kidneys. Not only did that conversation never happen with her urologist, but she had never taken mushrooms in her life. Now, she was also receiving workers' compensation and feared that a false reference to illegal drug use in her medical record could have consequences for her claim, employment or insurance. Her doctor has apologised, blamed the transcription error and said she'd review how she uses AI in her practice, but of course couldn't explain how that fabrication actually happened. George, this is a hallucination that had real teeth. Luckily, it doesn't seem like any permanent serious effects resulted from this mistake, but it could be. And I'm sure these things are happening with some regularity. So what's your read on this?
So just as we're starting to believe that AI is going to replace the doctors, you come up with this story showing how AI can actually stuff it up as well. And of course, as we know, real doctors never make mistakes. I mean, this is obviously just something exclusive to AI. It would be a gas that an AI scribe can do something as stupid as call a patient a mushroom head, or whatever that colloquial term is for the uses of psychedelic mushrooms. The real story here, of course, is that the doctor using the AI scribe didn't pick up on the error. And yes, it didn't become visible until a couple of documents down the line after the operation, when it somehow or other popped up in the surgical report. Governance is so important this fact. We keep on talking about the AI scribes automating the note-taking, but the reality is that note is the responsibility of the doctor or healthcare provider who spoke, that it's their words that are being captured. So governance really remains their issue. And the challenge, of course, here is that these tools are being sold as these huge time savers. You don't have to sit around in your pajamas at night and doing your notes. Although I'm never quite sure whether any of the doctors I know actually never did sit around in their pajamas and do notes, but that's another story. If you then have to add the time to go through the whole document with a fine-tooth comb, and some of these documents can become quite verbose and structured in ways that may or may not make sense to the clinicians at that time, it takes away a big advantage. So the original selling point was you save hours a day. The research started to show, in actual fact, if you do it properly, you actually save minutes per day, but you do end up with a nicely formatted set of notes, which is shareable. When I've spoken to some of my colleagues, some of them love them, some of them hate them. More love it than hate it, I have to admit. They do find it very useful, but at the same time, they've also had to change the way they document. They have to change the way they talk into the AI scribe to get the notes. And they've been fine-tuning it over the time to make it better. I think one thing this does point out is how important it is for those notes. If you're going to computer capture them and computer generate them, then share them. They're now in a computer readable format. And we had earlier on in our podcast, Liz Salmi talking about open notes.
Yep.
I think now this is the perfect inflection point where computer-generated notes should be openly shared with the patient. And in this case, this patient would have picked up on the fact that something was wrong. And we've seen in study after study that often patients find things in their notes that are wrong. I've got some stories. I remember when I was a resident at the hospital, someone who I've known for many years rolled up to the hospital into the emergency department. Anyways, I happened to be going past and his wife told me he was in the emergency. I went and had a look at it and picked up his notes. And they're written in plain sight on his notes. This is a guy with really bad pulmonary disease, nicotine-stained fingers, nicotine-stained moustache. And the junior doctor had written non-smoker. And I went, yeah, how'd that happen? I said to the junior doctor, I said, what happened? How'd you get non-smoker? He goes, I asked him and he told me he doesn't smoke. I said, didn't like looking at his hand, didn't he? He goes, let's go and have that conversation. I said, yes, Mr. Smith, I hear you're a non-smoker. He said, yes, I stopped this morning because I couldn't breathe. I go, yeah, okay, that's fair enough. So again, making sure that the notes are available in such a way that everybody can share them. And we need to do more work in AI Scribes. AI Scribes came along very suddenly. We've seen huge growth. We've seen a couple of local and international companies really take the ball and run in this space. We now need to start thinking about some of the unintended consequences are. We'll do a lot more research, but also understand what the risk-benefit ratio is. If for every 10,000 notes we get one wrong, I would suspect that's probably better than what we are doing now in human written notes. So let's not catastrophize the situation too much.
No, that's right. And we talked about it before. It's really important. You know, it's the clinician's ass on the line at the end of the day. And I don't see that changing anytime soon. It might in the future, but at the moment, APRA is very clear that you are responsible to check. But of course, we've also covered on the pod a lot of literature, and I was surprised how fast it happens, that, we check it a couple of times and then go, oh, look, it's right. And it doesn't make mistakes. And then we become really complacent. And so that's going to be an ongoing problem for clinicians. And then we see that the TGA, Australia's regulator, I don't think any of the scribes on the Australian market are approved by the TGA, because if they determine that if it's a transcription summarisation service, doesn't need to be regulated. But my understanding is that the TGA have acknowledged that some scribes may already be in breach of regulation because they do offer clinical suggestions beyond pure transcription. So we'll cover it in a future episode, but I understand that the TGA has been doing a review into scribes and their report is due in coming weeks. So we will cover it as soon as it comes out.
Yep. And of course, if this was one of Vinod Khosela's AI automatons, then who knows what would have happened with these notes. So there's lots of opportunities here to explore how the AI scribes can play a role.
Yeah, that's right. And look, the failure here was very much a socio-technical one. So shout out to all the clinical informaticians listening who know everything about there is to know about socio-technical aspects of digital health. So it was very much a socio-technical error. All right, George, let's move away from AI for a moment at least, and we're going to be talking about wearables. Now, regular listeners to the show would know that we often discuss advancements in consumer tech and particularly wearables. The reason we cover it on the show is because they've always laid outside of traditional healthcare, but we believe that in the future they won't necessarily be outside of the healthcare system as we move towards a health sector that is able to offer more personalised medicine thanks to tech and new business models that wrap around it. Well, even though that future might be a ways off, we are making progress. Now, George and I were at the HIC conference a few weeks ago, and at HIC, Simon Cleverly from the Department of Health, Disability and Ageing announced that regulations expected by February 2027 will allow the healthcare identifiers to be linked to wearable and biometric devices for the first time. So for those of you unfamiliar, in Australia, we have healthcare identifiers. If you are a practicing clinician, you have a healthcare identifier. If you're a patient in the Australian healthcare system, you have a healthcare identifier. And if you're a practice, a hospital or a clinic, you also have an identifier, and they are all unique numbers. So with this new regulation, healthcare identifiers will be linked to wearable devices for the first time. Now, it's really important. This doesn't mean your smartwatch data or your Oura Ring is automatically going to flow into my health record next February. But what it does mean is that the regulatory foundation for providers and software developers to connect the data from these wearables, from home monitoring and virtual care devices to the correct patient will be a reality. But of course, connecting the data is only the first challenge. Now, a few weeks ago on the pod, we discussed a pretty large study, which was across 6 countries, which found that doctors doctors saw value in wearable data but faced barriers to actually accessing it and using that data. Well, the American Medical Association has now issued guidance to their members on access and use of wearable data. Now, those guidelines, we'll put a link to the show notes, so they're supposed to be practical, and I'd be keen to get your thoughts, George, because personally, I didn't think they were that realistic for busy clinicians. So Australia might be building the rails for wearable data, which is great, but the question here is, can healthcare turn that data into trustworthy and actionable clinical information? What are your thoughts, George?
Look, we've discussed wearables a number of times on the podcast, and now you and I are both big fans of wearables. I don't know how many watches you've gone through, but I've got a drawer full of watches and chargers and devices, and going back to my original little Fitbit, which used to clip onto my shorts. The reality is these devices are now becoming closer and closer to medical grade, but one of the limiting factors has been the lack of being able to take their data and put it into a clinical record. You mentioned HIC. HIC was a great event in that I managed to catch up with our old friend Mukesh Hackerwell, and Mukesh talked about on stage how important the work they did back 10, 12 years ago on healthcare identifiers was to enable us to have a concept of a national health record. You can't just assume that the data in someone's record is their data without some sort of good identification mechanism. And we've got both individual healthcare identifiers, provider healthcare identifiers, facility healthcare identifiers. It's quite a complex interweaving system. And whilst it sounds boring, it's very regulatory. Without it, the data systems that we have now would not be able to work. So adding wearables into that technology is a pretty major step forward. It's no simple task.
Cool.
Yeah. There's dozens, if not hundreds of companies producing these devices. The fact is we keep on beating the drum around standards. And even 15, 20 years ago, the Continuum Health Alliance was talking about the need for these new devices to work on standards. And identity standards are a critical part of that. The key, of course, is that we need to then move beyond just demonstrating the fact that we can move the data. What do we do with the data? And does the data provide us with useful information that we can use for making better clinical decisions and improving real outcomes? Now, I don't know about you, but the private health insurer I have actually has a thing where it actually allows me to upload a number of my steps and it gives me some rewards. But taking it to the next level where we're using this information to make clinical decisions, not just at an individual basis, because the other thing we need to think about is that by having this information across the whole population, we can start making population-based decisions and looking for where things are working well and where things aren't working well, and take the learnings from the good to the bad and work out what's happening. So there's lots of opportunities here, but we need to make sure we've got the clinical evidence that it's working. And to do that, we need credibility. Credibility means proper research around it. It needs us to do some validation, so making sure that the data that we're coming from the systems is accurate and working well. We need to have effective workflows. We can't require our doctors at a bedside visit to say, now I need you to take your watch off, put it on this little piece of metal here, type in your PIN number, wait 45 seconds, watch it upload to the cloud. The workflows have to be functional and utilitarian. It just highlights the need for research to think about what we can do with all these new data sources in the way we deliver healthcare that add on to what we're already doing. The challenge we have is that we still consider ourselves to have a pretty good healthcare system. Doesn't mean we can't make it better.
Yeah, look, congratulations to Simon and the team at the department. You know, it's a huge amount of people, not just within the department, but with Sparked and everything that work together on putting these standards together and the policy and regulation around it. We'll keep an eye on this because it's not just the wearable data themselves, it's actually then the software that the clinicians use, how fast they are to adopt and being able to bring in the information in a format that actually is valuable rather than just data downloads. So yes, we will keep a track on that. But I thought that was really interesting, especially the AMA thinking it's so close to happening. The AMA in America, that is, that they put out guidelines for their clinicians.
Look, and I think, again, that's a good sign that the AMA is getting engaged in these conversations and not doing their normal thing of saying consumer wearable devices are outside of our domain. Understanding that the world of healthcare is getting larger and we need to work with players like Apple and Samsung and Google and whoever providing these tools, but also consumers are using these tools to make their own decisions now. So we need to make sure we can help them validate the quality of the data they're making decisions with.
Yeah, that's right. Well, time for a quick break. And when we come back, we're going to be looking at why GPs are doing so much care coordination but receiving so little timely information, and that's at a global level. And we're also going to be discussing whether Google's new AI video doctor means that virtual care, does it still require a clinician? Back soon. Welcome back, everyone. Now, we're going to be stepping away from tech for a moment to talk about something more fundamental, whether the basic machinery of healthcare actually talks to itself. Now, the Commonwealth Fund has just released a major international survey, primary care physicians across 10 countries, including Australia, Canada, France, Germany, Netherlands, Sweden, Switzerland, UK, US, like everyone. Now, the question was simple. When a patient sees a specialist, gets admitted to a hospital, or needs a social service, does their GP actually find out, and in what time frame? The headline finding, though, is sobering. Not a single one of the 10 countries has cracked this. Frequent, reliable care coordination just isn't universal anywhere. But how each country fails is genuinely different. Australia actually comes out looking strong on one measure, weak on another. So more than 8 in 10 Australian GPs said someone in their practice frequently coordinates care with specialists or other healthcare providers. It's one of the strongest results in the survey. So yay, Australian GPs. But fewer than 1 in 10 said they actually receive a specialist report within a week of the patient's appointment. Australia has joined Germany and the United Kingdom at the bottom of the 10 countries on that measure. George, where do you want to start with this report?
First of all, the Commonwealth Fund is one of my go-to places for high-quality health research. They do a really good job of analysing data. The Commonwealth Fund is nothing to do with the Commonwealth. It's based in New York, just to make life confusing. And it doesn't focus on Commonwealth countries. It focuses much broader than that. When you look at this report, it basically is telling us that what we identify as high quality care, which means coordinated care between a team of healthcare providers aiming to provide better outcomes to individual people, just doesn't happen. We all know it should happen. We all think it does happen. But the reality is there's so many complexities in the system, not necessarily because the data is not available, not necessarily because the practitioners aren't keen or don't understand the value of it, but the technical aspects of it just make it more complicated. They describe the Australian GPs as severely bottlenecked by a lack of systemic, automated and timely communication back from the rest of the healthcare sector. And we've all seen examples of that where people have gone into hospital and their discharge summary now, in some states at least, it'll go to My Health Record. So My Health Record provides a conduit for that. Their specialist letters go into the nether, and often we rely on the individual to be the coordinator of their care and of their health information. Now, that's fine for a 35-year-old, highly educated person with a single disease. An 85-year-old with 5 comorbidities, mild cognitive impairment and 14 medications, expecting them to be able to do that is probably asking a lot of them. So we need to think about what is it that we need to do? What are the barriers? I would argue many of the barriers are reimbursement models, the public, private, state, federal divide, all those sort of things where the team looking after you just don't communicate because they live in different worlds. Specialists are a great example. I'm fairly fortunate. So if I or one of my family members go to a specialist, I usually go along and I become the conduit for that information. But not everyone has a medically trained uncle or nephew or brother in the family to do that for them. So we either need to think facilitate the role of the consumer and give them the tools to make them to be able to do it better. And back in 2007, 2008, that was part of the vision of My Health Record, or back then, the person who controlled the electronic health record, the idea that at least the information is in one place. Therefore, the excuse for not being able to find the information becomes less of an issue. Sure, it's a shoebox of PDFs. It's not ideal, but at least it's there. At least you know where to go access it. Now, we had the problem, of course, that half the population didn't use it. 9/10 of the medical profession didn't upload information into it. So now we have sharing by default. So at least we no longer have an excuse for not being able to share our pathology results and our radiology results. But all the other communication still gets lost in the ether. Specialist letters take 2 or 3 weeks to come through. Now, AI scribes will be part of the answer to that. So we've got a whole bunch of other solutions. But I don't think the fact that we have these poor results, to me, is inexcusable. We've known for decades that coordinated care. We actually have a coordinated care trial here in New South Wales, which demonstrated the value of it. We just need to break down the barriers that are stopping it and reward those who are doing it well and punish those who aren't doing it well. I think this is where we need to get to.
Yes. And of course, because this is the Pulse podcast, we would also say that, yes, technology is a fabulous tool to use to connect this data and to be able to have it shared quickly and relatively seamlessly and easily. Certainly the Connected Care demonstrator event that the Commonwealth has put together, we were at HIC with that. That was one of the key parts of every story. The GP, all the way along as the care coordination point, knew exactly where the patient was at any given time and what was happening with them. And of course, as you point out, George, the information back to the patient as well.
Look, 15 years ago, the Connectathons at HIC, we demonstrated that we could share, we could pass the information around. Now,
we did.
It is not a technical barrier. We know we can do that. And we saw it in Australia when we had the big debate between opt-in and opt-out. That was one part of it. But if healthcare providers, who are the ones who would benefit most by having access to this information to ensure they deliver the highest quality care, don't go to the trouble of uploading information and sharing information, then we really need to pull the various levers. And whilst I do believe in carrots, sticks aren't a bad thing either sometimes.
Yeah, that's right. So let's go to the fifth and final story today in our hot topics. So we began this episode with a claim that autonomous AI may soon outperform doctors on a range of different cognitive tasks. Well, our final story today, we're going to be ending with Google demonstrating what that could look like inside a virtual consultation. So Google Research has developed a video version of AMIE, which we have discussed before on this pod. Now, it's an experimental medical AI. Now, rather than relying on text, as we've discussed before, it can actually talk with the patient, observe audio-visual cues, and guide them through parts of a physical examination. So basically, Google's AI tool, is conducting real-time video consultations, albeit in a lab. Now, we're looking at full audio, full video, guiding patients through these physical exams over a call, the same way a telehealth doctor would. Now, in a large randomized trial, there was 100 clinical scenarios, 300 consultations, and 30 board-certified primary care physicians involved as either participants or evaluators. So independent clinical evaluators rated AMIE's video consultations basically on par with or even better than real doctors on history taking, diagnosis, treatment planning, and even physical examination. Real human doctors, though, they still won out on one thing: rapport, human connection. So patients did prefer AMIE for explaining their condition, but when it came to feeling truly cared for, the humans still had the edge. Yay, humans. So Google says AMIE is not ready for clinical deployment yet, but if an AI can see, hear, interview and guide a patient through a virtual examination, I think we need to ask which telehealth consultations genuinely require a clinician and which ones require one only because until now there was no alternative. And George, I'd love your take on this because I'm working with a digital health agency and the entire industry really on telehealth and virtual care and what needs to happen to improve the systems, make sure patients are well taken care of, a strong clinical governance. And one of the definitions that we discussed in our very first meeting was the fact that telehealth, by its very definition, in terms of the way government defines it, it involves a human clinician and a human patient. And what happens when telehealth or virtual care doesn't actually involve a human doctor? And here we have Google showing in the lab anyway, they're coming up with some pretty good results already.
Maybe in the near future, human clinicians will be that quaint little thing from history we used to think about. Remember the day when a real doctor used to come and talk to you? So yes, look, great link up with our first paper from the Kostler paper, that the move from text-based to, lo and behold, now adding video and audio. And I love the name AMIE, Articulate Medical Intelligence Explorer. I'm sure someone spent a lot of time, or maybe they used ChatGPT to find that acronym, but it's good. Look, this is a really exciting paper. I'll tell you why. Because technically, what this has done is taken a whole bunch of agent-type architectures, tied them all together with various data sources, overlaid some algorithms, and provided what is, for all effects and purposes, a virtual tele-doctor. Now, I've mentioned him quite a number of times over the years of our podcast, but the emergency medical hologram from Star Trek Voyager really isn't that far away when you start looking at this. This is capturing information. Now, at the moment, it's very much at where I was as a medical student. This is the way we used to evaluate second and third year medical students. We had scripted patient actors. They had very well-defined cases, and it was our job to get a history out of them and come up with a diagnosis. And that was the very beginning of our medical career. We kept it simple and straightforward so we could develop the skill set. But as we've seen with AI tools, they develop skill sets much faster than what we do. So from me being a second year medical student to being a proficient doctor was quite a few years of practice in between. We saw that when they first introduced the DeepMind computers to Go, within a couple of weeks, it had become the world master at it. So they can pick up skills very quickly. And one of the things that did come across in this demonstration was that the consumers actually identified empathy. They actually said that this virtual doctor that was treating them actually demonstrated empathy. Now, to put it in context, there were actors with fake symptoms, so maybe the empathy can be as fake as well, who're not quite sure. But the reality is this is a huge advance going forward that we really need to keep our eyes on, because the reality is that if this works for 70% of the population's need, that frees up a huge chunk of resources. We're now sort of at that inflection point where if we can virtually manage chronic disease, and we keep on talking about chronic disease being the huge challenge of our era, if we can automate and scale the management of chronic disease to the point where it becomes much less of an issue for the healthcare system, we can then start thinking about what do we do next? How do we help pediatric cancers? How do we help glioblastomas? Now, if you're a doctor now, you'd probably be thinking, okay, what does this mean for me? I'm lucky. I'm at the point in my career where I can hang out my shingles, so I can sit there and watch this with excitement. If I was a 30-year-old doctor who's just started their practice, I'd probably be worrying a bit about whether this is going to replace me. But I think we need to shift the thinking to not how is this going to replace me, but how does this augment the system and give me new roles? I go back to our good friend Amandeep and her conference, Creative Careers in Medicine. Some of these careers in medicine are going to be very different to what we thought we trained for when we went through med school. We need to work out how we're going to do that.
Yeah, it is early days what Google have done, but that's sort of the point. It blows my mind, the idea of an AI being able to perform a physical diagnosis and it rates. Like, there's no cold hands touching a patient and palpating the skin.
I have to give credit to Google here. They did this as a research product. This wasn't a product manager coming out saying, we have a solution. These are guys doing deep research. We know that they are doing the hard yards behind the facade. And we've seen some spectacular failures as well. And to their credit, they've identified those spectacular failures and moved on. But this concept of a total virtualized healthcare provider, again, it's not for everybody and it's not for everything. But when you look at what happens at a general practice now, most GPs will tell you that probably half of what they see, they probably could have done with a text message, but because of the current reimbursement model, they have to come into the practice and they have to sit in the waiting room and they have to spend more than 6 minutes, but less than 20 minutes with the doctor to get the right reimbursement code and whatever. We just need to start rethinking this, especially in light of the fact that from a population perspective, there's still a lot of have-nots in our society who aren't getting access to care.
Exactly. Yeah, and that's a global problem. We want to make sure these technologies actually improve access to care directly as well as indirectly. So someone with a more minor complaint maybe ends up with an AI doctor doing a certain triage, making that appointment free for a real life human doctor, that type of thing. But it also made me think about Bhavesh Patel, because we spoke to Bhavesh earlier. Was it this year or end of last year?
End of last year, yeah.
Time just keeps flying by. I'll put a link to the show notes, but go back and find that episode for Pulse Potties who didn't hear it originally. But Bhavesh, amazing paediatrician, surgeon in Queensland, and he was like, I'm not available 24/7. I would love to be, but sometimes I have to sleep. Sometimes I need to see other patients. And so he created an AI avatar of himself, and it looks very much like the real Bhavesh, although it's clearly labelled as an AI. And when you've got a question about your surgery or about how your kid is going, you can talk to AI Bhavesh at 2 a.m. in whatever language you need if English is not your first language. So there's all sorts of applications of this exciting new technology.
Absolutely. The technologies are amazing. The research and innovation is amazing. The bottleneck still seems to be the governance model and the reimbursement model, we should be paying for value, not for just the minutes on a clock. I guess it's the biggest challenge. And if we can release those minutes in the clocks to enable someone, the doctor or a nurse or a physio or whoever it is, to spend that quality time doing stuff that only they can do, I think we've got an opportunity to change the healthcare system.
Yeah, always good discussing these topics with you, George. And I know our growing listenership really value your input. So thank you for today. So to wrap up the show, across all of these stories, we've discussed that AI may soon outperform clinicians at some cognitive tasks, but an AI scribe can still invent a damaging detail in a patient's record. Australia is preparing to connect wearable data to health infrastructure, but of course, clinicians still need to know what can be trusted, who is monitoring it, and when to act. And while Google's AMIE suggests some virtual consultations may not always require a human clinician, the international care coordination data reminds us that healthcare depends on a lot more than isolated moments of diagnosis. So thanks for the conversation today, George. That was
that's an amazing summary, Louise. I think you've captured 5 very disparate stories into one fantastic summary. Well done.
Yeah, got them all with the segue there. George, do you have any recommendations for the Pulse Potties this week?
I've been doing a little bit of reading over the weekend, and I came across an author called Annie Jacobsen. So Annie Jacobsen is a sort of political writer, but she's published 2 books recently, which are a little scary. One's called Nuclear War, a Scenario, and one's called Biological War, a Scenario. And as you'd expect, they're quite interesting discussions about what the
So we're ending the pod on a positive note.
Yeah, so what the end of the world
George?
looks like. My concern is that her next book may be called AI Wars, so I'm keeping my eyes open for that one. But after reading those sort of books, I decided, yeah, life's short. So I went dancing on the weekend. We went to a Greek night and we danced till 2:00 in the morning to make up for it. So,
very good.
If all else fails, go out dancing is my recommendation.
That is a fabulous recommendation, George. I cannot top that one as someone who is always up for a dance. And just one shout out from me, which is just a reminder. We've given the plug the last few episodes. If you're a clinician and working in healthcare and there is some level of AI in your frontline work, there's an international group that really wants to hear from you. They are looking to understand the gap between AI policy and the reality on the ground in healthcare. They really want to hear from frontline health workers. The deadline to answer that survey is the 2nd of September. So if you were meaning to, but you haven't got around to it yet, check out the link in the show notes and encourage you to put your voice forth in that research study.
The other thing we should probably note that Creative Careers in Medicine is coming up. So those of you who've got the opportunity to get up to Gold Coast.
Oh, of course.
I hear the MC this year is amazing.
We'll see if she does a good job or not. She may have a new suit for the occasion, but I'm looking forward to Creative Careers in Medicine. I know we go to a lot of healthcare conferences. You and I are very lucky to do that and have done for a long time. I mean, we met at a healthcare conference, but the Creative Careers in Medicine, it is a entirely different ball game. Like, it's so different and very cool. No one gets introduced with their bio because the point is you're an impressive person or you wouldn't have been invited to speak on stage. And people get up and they tell their own stories. People doing all sorts of crazy stuff, impressive stuff. They're not traditionally practicing medicine, or if they are, the traditional component is just a small part of their life. It's just fascinating. So yeah, looking forward to that on the Gold Coast. Tickets are still available. So if you've been meaning to get up to the Gold Coast and get a ticket to CCIM, please encourage you all to do that. And if you would like a code from George and I, just feel free to reach out to us and we can get you a code to help with the registration costs.
Sounds good.
All right. Thanks, George. If you could please read us out.
So thank you all for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Special thanks to Emily Mara for her support. Big thanks to everyone for listening. Make sure you subscribe, follow and rate us wherever you get your podcasts. Visit pulseit.news to catch up on the news from Australia, New Zealand and Ireland, and send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. See you, everyone.
See ya.